Good afternoon, everyone. So, after that highly exciting talk by Dr. Ravi, we're going to come back to the ground and to something that is very relevant to our setup in India. So, living donation has actually managed to expand the reach of liver transplant, both in terms of where it can reach and also in terms of the numbers that we are doing in today. Especially given that in 2023, 80% of all the liver transplants done in India were from living donors. Now, compare this with the US, where only 5 to 6% of transplants were living donor liver transplants. That brings along an additional burden upon the transplant team to ensure that the donor surgery is safe, to avoiding any mortality. Any mortality is unacceptable. And we also want to reduce morbidity to as close to zero as possible. So, although it's been 30 years since the first living donor liver transplant was reported, there is very little data on long term follow up. One of the reasons being that donors, being healthy, the people who donate, who are not sick and they undergo the procedure to help their loved ones, uh, they do not require any kind of medication, long term medication, follow up testing. So, the sample size is small and there is a high loss to follow up, and also in long term follow up with donors there is a recall bias. So these are the reasons why we don't have robust long term data in follow up data in donors. So I'm going to talk about the incidence, the distribution, the risk factors, and prevention. But if I actually put it all down on a table, it will look like a list and it will be utterly boring and also not very relevant. So what I have chosen for this talk and the time that is given to me is that I've looked at what are the most common ones that are of relevance to us, and given that we are many of us are surgeons, and also some that were that are less expected and that we don't look out for. So I thought that would be something that we can learn and grow when we do this. So this is a recent publication which looked at a large number, probably the largest number of donors, 61,000 donors, and with an average follow-up of 2.9 years, comprised about 187 papers put together. So the overall incidence rate of complications was nearly 25%. But luckily, the majority of the complications reported were minor, grade 1 to 2 complications, which is 17.34, as you can see from this figure, while the grade 3 to 5 complications were 5.5. And this is the distribution of complications. So, as expected, these complications were higher during the early post-operative period, about 30 days following the donor hepatectomy, and tended to decrease over time. And the mortality rate was low in this pooled study. It was 0.06%. So this is just an extension of that to show that about 2% underwent reoperations and about 4.7% of them were readmitted for addressing various complications related to the liver donation in these people. So some interesting facts. Does center experience matter? In India, we have several centers do transplants. It's not only the high volume centers, but many centers are average to low volume. There are newer centers coming up, newer hospitals coming up all the time. So early reports, especially from the Hong Kong group, reported that with experience, the 1 to 50 transplants versus the second half 50 to 100 transplants, there was a drop in the incidence of major complications from 14 to 6%, as well as minor complications from 26 to 8%. But this study found that in the pooled analysis of all the data published, there was no significant trend in early versus late numbers. This could be explained by the fact that there are more trained surgeons now, and since they experienced people tend to move from one program to another, this learning curve may not be applicable to newer programs or smaller volume programs. The other good thing was longer surgery did not necessarily mean increased complication incidence, which is like if we are meticulous with the surgery and avoid complications, then the duration of the surgery does not impact complications. However, intraoperative blood transfusion requirement was one of the significant factors associated with an increased incidence. In this study, 2.2% was the total number of donors transfused, But any donor receiving 1 unit of blood transfusion, the morbidity was 2.7 times more. And if the transfusion exceeded 1 unit, then the complication rate was 4.5 times more. So that is the magnitude of increase which is related to blood transfusion requirements. So we have an idea that larger the volume of the liver removed, more the incidence of donor morbidity. However, based on the lobes donated, as can be understood, right lobe was the total complication was 26.6 and the major complication 6.6. Left tended to be lower, about half or less than that, 12.3, but major complication rate was again 5.2. Left lateral, because we leave behind an ischemic segment of the liver in segment 4, more than the left lobe itself, 12.7, and major around 6.1. So these were related to the graft types. Coming to how they are related to the organ systems, this is something that is often not a part of our thought process, like psychological complications being the highest number of being the organ system with the maximum number of complications. Probably we wouldn't even consider it in the organ systems that we when we are evaluating donors. This was followed by wound related, respiratory, and other complications. But cardiovascular complications, you can see, were very low, possibly because they are well selected donors. They are extensively worked up pre donation to rule out any underlying cardiac comorbidity. So let us address some of these important ones. Mental health, when it comes to it, is a frequently overlooked complication. And different studies have reported an incidence between 3.1 to 7.6% incidence when followed up over a 4-year period. These complications tend to occur longer into the post-donation period. More than 3 months was the median duration. And 50% of donors with mental complications had experienced a post-operative complication. So how does this manifest? These patients present with either depression, anxiety, or substance abuse can be as high as 21% given the situation or the area where they hail from. In areas like East, where Korea, for instance, the suicide attempts and suicides are especially high. 0.25 was one reported in a paper. But then if you see the overall, the cultural pattern prevalent, about 40% of deaths can be attributed to suicides in the under 45 age group in that area. So culturally, cultural factors also play a role. What are the risk factors that affect mental health? If the donor has a longer hospital stay post donation, donor of female sex, high BMI, employment status of the donor, education levels, lower education, higher mental problems, and of course, recipient mortality. Now, it is important because mental health is quite likely to be underplayed in a nation or our own context because of cultural stigma associated with the seeking mental health support. So, what are we doing, or what can we do to reduce or minimize this complication? So, of course, we all give every opportunity to change for the donor to change their mind prior to surgery. We should be especially cognizant in ALF or ACLF situation where the time available is very short and therefore the pressures may be high. Having an independent donor advocate who's usually a medical social worker in our context helps because they interact with the donors at a different level than they do with the medical personnel of the team. Again, independent psychologist who assesses and gives the thing. So it goes such that one of my psychologists used to give a pre-printed saying donor has no complications found, donor is fit. So there was one alcohol-related disease recipient in which they had given the same. So I said, how come you gave clearance? Because I felt that this recipient needed further counseling sessions because I think he's at a higher risk of recidivism. The explanation given to me was, my peers have told me that this patient is sent to you for clearance and your job is to give clearance for this patient. I said, no, when I'm sending it to you as an expert psychologist, I expect you to exercise your discretion and your judgment. And if you say that the patient is not fit for a transplant, then I would do whatever is necessary to make them fit for a transplant. Similarly with the donors, so if they do find, they should be encouraged and given the autonomy to advise further counseling sessions, whether it be peri-operative period or even into the post-operative period. And we have come across this, especially when there was a recipient mortality in which the donor, who was the son, really went, and we had a very hard time persuading him to undergo psychological counseling. So again, encourage. So we should encourage post-transplant counseling, and this support should be continued, preferably through the donor advocate. Quality of life again is underreported. Most donors would report a decrease in the physical as well as psychological domains early post-operative period. But 6 months post-donation, they align with that of the general population. However, in case of certain such situations like death of the recipient or regretting donation as an afterthought, or if they don't have family support, then they may report persistent lower scores in fatigue, chronic pain, and psychological distress. The second most important complication, and that is very relevant to a surgeon, is wound related complications. So, if you can see, the incisional hernia report varies from 0.6 to 8.4%, but in this large study, it was about 2.2%. So, these are the other ones. I'm not going to go into them. But again, as Dr. Dinesh set a nice platform, the advent of minimally invasive surgery being lower, it is expected to be lower than compared to open surgery, wound related complications. And in early reports, it has also been reported to be lower than open surgery. However, long term follow up results are eagerly awaited on whether extraction site complications or port discomfort, site discomfort at the incision site or the post port site, because they tend to be the most common persistent symptom in donors after donation. So, coming to general complications, these are problems that we don't consider in regular surgeries, whether they be liver transplant recipients or even the HPB GI surgeries that we do. But donors have these complaints which they pay attention to, and it really bothers them a lot. For instance, alopecia in young males or females, it's something that not only the donors but the families complain bitterly about. The other thing that happens is often numbness or neuropraxia or kind of paresthesias that occur in these patients. Usually they are due to pressure, and most programs that are doing have evolved techniques of basically taking care of them, yet they tend to happen from time to time. We also get problems like rash and burns because of allergy to cleaning agents or from the cautery. But what is important is that these are things that we need to be cognizant about, and we need to handle them with compassion and care, so that we don't dismiss them off saying, oh, this is a non-serious complication, forget about it, it is going to. Because I know donors have gone to, if we don't offer them that treatment, they go to other people, they take minoxidil and they all those things, which we would rather pay attention to them, treat them empathetically, and make sure that it is taken care of. Hypotension is another thing that is reported, but then hypotension, what happens is most centers tend to follow a hypotensive anesthesia protocol during parenchymal transection to reduce bleeding. So this perioperative hypotension, it's not very sure that it's intraoperative, which is continuing on to the post-operative period. Again, coming to perioperative, intraoperative in an old paper was reported in 2.5% of the donors. They related to venous lacerations, capsular tears, clamp slippage, which are things that we do encounter from time to time. Post-op hypoxia from narcotic dosing. An interesting fact was 11 months after follow-up residual liver volume, one study studies reported that they were almost 88% of the liver volume was restored. It did not reach 100%. It remained at slightly lower than what we started off with. So that was another thing. Average ICU stay duration was 1.7 days and hospital stay 11 days. So another very important complications, biliary complications in 5 to 15% of bile leak has been reported in 5 to 15% of donors, and in the study it was 4% only, which is within less than what has been reported earlier. But many of these bile leaks also ended up in strictures, and they persisted in about 1.7%, requiring readmissions, interventions, either endoscopic or PTB, percutaneous, and even surgery. And there was this interesting study done in China where they followed up patients with post-donation and compared their biliary complications with that of a general population, and said lifetime risk of developing biliary tract disease is 49.7%. Whether it's clinically important or not, we don't know yet, but this is something to be cognizant about. Again, another study where they did long-term MRI in donors showed dilated bile ducts in 60%, orphan ducts or disconnected ducts in 69% without symptoms. So, when it comes to the liver complications, most of the features were consistent with post hepatectomy liver failure, and most of them responded to supportive management, and there was no mortality reported in this group of patients. So, this was something that I found interesting. Where the donor, this was in an early paper, 2008. So, with our present day imaging technologies and with development in surgical anesthesia techniques, this is something that we don't come by as often. But this is something where the donor procedure is started but was not completed. And in those, if the donors face a problem, then it's additional hit for them. So this is something that I found interesting and wanted to share with you. So to summarize, liver donor surgery, albeit safe, is associated with complications, unique complications, and all of them should be considered very seriously because we want to minimize them, because the expectations from us as transplant teams and transplant surgeons are changing over time. The margin of error is coming down. We're being squeezed from all sides. Understanding of these complications is the first step to avoiding or at least minimizing them if they cannot be avoided. And long-term data regarding donor minimally invasive surgery is eagerly awaited. Thank you.